Hi, I'm Dr. Craig Murphy, and welcome to the second part of the pre-hospital ultrasound machine and mechanics. We started out with part one, where we looked at what POCUS means and how basic sound transmission will come from the probes and the machines themselves, and a little bit about orientation and some of the terminology. Now we'll continue that with some sound foundations and going a little bit more into the artifacts and sonotextures on various images. Remember, we're trying to make you both sono-skilled and sono-savvy so that maybe you can't create every image, but you'll have a good comfort in interpreting a lot of the images as your skill set goes. We talked already about how sound is a repeating wave coming from a crystal that's activated through electrical discharge in the probe. And each of those creates a cycle in a period of time, which is known as its frequency. So when we have frequencies of ultrasound, we're talking about millions of hertz per second. But if we had a 2-second frequency, it would be, or a 2-cycle frequency, 2 hertz would be 2 cycles per second. If we take the distance this takes to travel, that would be known as the wavelength. And the wavelength is usually in micrometers or millimeters. And is a matter of how thick the crystals are that are cut and put into the probe, which is why each probe has a specific limitation and skill set for which it was created. And that's one of the reasons you have to pick the right probe for the right job. When we look at the height of the cycle that the sound is producing through the crystals, that's known as amplitude. And we won't get too much further into the physics of this, but this is a square root of the intensity or power, which is in decibels. Some of these things help understand why the probes are unique for each tool and why you have to select the right tool. Also, if you get to a more expensive machine than the handheld, you'll also understand why some of the buttons will help you adjust some of those parameters. Remember, we talked about the basic scanning conventions where the probe marker should be to the right side of the patient or towards their head, depending on which way you're scanning. So in this particular pericardial scan, you can see an apical four-chamber where the probe marker is to the right side of the patient, and if it was to be turned 90 degrees towards their head, that would be the other convention for a long axis scan. Remember, the top of the screen is what the probe is touching, and deeper into the scans takes more time, so the pixel is put further towards the bottom. For instance, on this particular image, we see that it's taken with a curvilinear probe because it's a wedge shape with a bite at the top. We can see the depth is set at 15 centimeters in total, and that would mean that the bladder is about halfway through that, or 7.5 centimeters. We can see an anechoic bladder, and we can actually see an organ in behind this, which is, in this case, it looks like the uterus. And you want to keep what you're scanning towards the middle of the screen. So here, this person has wasted a little bit more depth than they needed to, and they probably could have gone down to about 13 centimeters and ended the image here, so that they can get a better picture without wasting depth. So if you have better resolution, you have better imaging, and as a sonologist, whether you're a physician or whether you're a point-of-care trainer or provider out in the field, you will always want to have the best images you can while still acquiring the images you need. So we have a couple different kinds of resolution that we want to think about. Grayscale resolution means that there is better black and white gradients, giving you prettier anatomical pictures. For instance, we can see this low grayscale resolution, black and white, and then we can see this very high grayscale resolution where there's a lot of fine detail and many different qualities of gray. This would be more like a phased array probe where it has lower qualities and more black and whites because it needs to keep temporal resolution or time of the movement specular object. And this would be more like a curvilinear probe here, where it has better grayscale because the objects that it's scanning aren't moving. That temporal resolution is an important component. You can't have everything because you'll affect the processing speed and the frame rate, and it will start to jump. Just like when you have a bad internet screen because your connection is poor and your screen takes a long time to refresh, you wouldn't want your heart valves to be doing that because you might overinterpret that screen processing error as a clinical error. Temporal resolution. This one is moving fluid in and out of the beating heart with quite good resolution for temporal resolution. But this is very low temporal resolution, not much detail, very simple movements. Spatial resolution is basically about how good the size and quality of the pixels are. So when you have poor spatial resolution, you can really only see gross objects here with no fine detail. Whereas on this one, with better spatial resolution, you get a lot more fine points between each component and therefore better spatial resolution. All of these things are happening in modern ultrasound, and we want to try to pick the right situation for the job. And that largely comes with probe selection and machine manipulation. The handheld probes that we're using for this particular training session don't have many options for these changes. However, it's still an important principle because these can be changed based on operator performance, depth settings, and whether or not you're adding things like color flow or other forms of Doppler. Now we look at this particular one and we can see that there are 4 different types of tissues that we're going to be scanning. If we go to something a little bit more traditional like a plain film, we typically will see a fluid density or water density, a bone density, and an air density. Here we can see air, here we can see bone, and here we can see soft tissues or fluid densities. In ultrasound, we get a little bit more designation in the soft tissues, where we can see water or fluid, like here in the bladder. This is urine, very close to water. We can see air in the lungs, which scatters sound and gives you this kind of grayscale artifact. Liver, which is kind of a watery substance, but it's got more parenchyma and cells in it than just water, so you start to see better echogenicity because it's both flexible and fluid filled with a lot of through transmission of the sound. So it's a little bit more grayscale. And then of course we have bone, which is seen by this rib here where the sound will hit the bone. It has such a big impedance change that it bounces much of the sound back to the probe at that level, which makes it appear very bright. But then there's nothing underneath of it because there's no sound getting through here. The rest of it has been turned into heat energy. And that's why it's called an absorptive shadow when you hit a bone, a scattering shadow when you hit air. Now let's move on to better understanding some of the common artifacts and why they can be either friend or foe. Remember, artifacts are anything that's projecting on the screen as wrong. It's not real. Artifacts are part of every imaging modality, whether you're talking about plain film, MRI, CT, or ultrasound. And you always have to be prepared to decide whether something is real or it's an artifact. In general, in medical imaging, it isn't real until you can see it in more than one plane, which means in ultrasound, you'll need to move your probe to make sure that's really fluid, or is it actually a sound artifact. Some of these artifacts can be created through operator misunderstanding, so therefore they're operator dependent in many ways, and that's why it's so important to understand them so that you don't overinterpret an image or underinterpret an image. Proper diagnosis relies on the ability to really understand this field of ultrasound and artifacts to ensure that you know what's real and what isn't real. And sometimes, as I said earlier, they should be there and they're normal, and sometimes they show up when there's pathology and they're abnormal in that particular scan. Now, let's look at some common artifacts. Number one, we've already talked a little bit about. The fact that sound has to follow the physics of nature means that attenuation happens as that sound projects further and further from the probe which originated it. And less of it will bounce back. The brighter the signal, the more amplitude the frequency has, and the darker the signal, the more attenuation that it's gone through. Scatter is associated with small reflectors like air or maybe a rough surface on a structure. Refraction is going to be bending sound, just like it is with light when you refract light. Posterior acoustic enhancement means that it's actually brighter behind where fluids sit due to the lack of sound energy that's being attenuated through that fluid, because there's a very consistent interface of stiffness and density in that tissue. And then there's going to be sound shadows, edge artifacts, under and over gain artifacts, mirroring, and reverberation. And I'll let you pause and read those basic definitions of what those are. But right now, let's look at some examples. For instance, by not controlling the machine properly, you may have over or under gain artifacts. Some of the handheld machines really just let you control overall gain. But in this particular image, you should probably increase the overall gain, because by the time the sound has gone from the top where it's overgained, it's been attenuated down into this area and there's no signal. It shows you like there would be a fluid collection inside this liver or kidney. So you're not seeing the image. That's an artifact, because we know this kidney extends down to here, and we know that the liver goes all the way down to the diaphragm. So the gain is showing the wrong actuality from just going through distance. So when you do turn up the gain, now you can see that liver does exist and kidney does exist down in those particular areas. Posterior acoustic enhancement. As the sound travels through all of these tissues, some of it is going to go through the fluid, and some of it is going beside where the fluid is. By the time it gets down all the way to this level, these sound lines have not been attenuated as much, so they have more amplitude, and therefore they come back as a brighter echogenicity below this fluid-filled structure. Whereas the stuff that's been traveling through at the sides is getting attenuated by passing through all the tissues in front of it, so it has less energy by the time it gets to this same level, and it appears dark. The reality of it is that by understanding artifacts, you would know that this tissue here is all the same, and there's just been a posterior acoustic enhancement, because some of the sound has more energy than others based on what it's passed through already. Now, just like in the last one, we have a cystic structure. This is actually a gallbladder. And in the gallbladder, we have posterior acoustic enhancement behind the cystic structure. But we have something stiff and dense that's absorbing all the sound right here, and this is actually a gallstone. Sound is coming down, hitting it, and because of the huge impedance change, it's bouncing a lot of the sound back. The rest is being absorbed as heat energy, and no sound is coming back from behind this dense, stiff object, and that's going to be a bone shadow. This is an absorptive type of shadow versus some of the other kinds of shadows where there will be scatter, that's from air, or there will be a bending of the sound, which is going to be a refractive shadow. And it's normal if there's a bone to be here that would create a shadow, like a rib shadow. This, of course, is in the wrong spot since it's inside the cystic gallbladder, and it helps us diagnose this is a gallstone. Here you can see the shadow in behind it. An edge artifact is actually a refractive shadow, and it's created when there is a difference between the impedance between two tissues, and it causes the sound to bend. And what we can see in this particular file is that the sound is traveling down the cystic structure, which actually has a stone in it, so it's creating a sound shadow in behind here. It's creating posterior acoustic enhancement right in these two areas, and it's creating an edge artifact by bending the sound in these areas, and the sound is coming down, hitting the edge with the impedance difference and deflecting it out wide like this, so that there's very little sound coming back from this edge, and that's known as an edge artifact. Also a refractive shadow. And the mirroring artifact is one that we want to see in some normal scans and not in some others. Here we can see a diaphragm with a spleen, but we're actually seeing a second spleen deep to the diaphragm. So the diaphragm is a shiny tendinous reflector, just like a mirror, and it's creating a mirroring line for the real spleen and the fake spleen. So if you're putting a needle into somebody, you'd want to understand this artifact to make sure that you're putting it in the real spleen and not the mirror. The other thing that we oftentimes see is that we would see the liver reflecting past the diaphragm and up into the thorax. Well, clearly we know that there's no liver in the thorax, and this mirroring artifact is normal when there's not fluid in the lungs. However, if there's real fluid in the lungs, that mirroring artifact would get replaced with fluid and a posterior acoustic enhancement that would associate with it. And that would mean that the artifact that should normally be seen is no longer seen because there's real fluid in the way. Now let's talk a little bit about Doppler. We talked about the idea that an ultrasound probe chirps out sound and then listens 99% of the time. But when you're talking about Doppler, it has a 100% duty cycle, meaning it's always talking. Therefore, when you put Doppler on, you're putting more energy into the tissues and you're doing more talking and less listening. Therefore, the resolution goes down. So you only want to put Doppler on when you verify that you need to know that there's flows to something. And what you want to remember also is that the red is coming towards the probe because it's actually sound waves being compressed, like an ambulance getting closer to you has higher pitches because of the compression of sound waves. And the blue would be the flow away from the transducer, and that's being rarefied just like the ambulance that's going away from you starts to get a lower pitch as a result. So the color is not oxygenated and deoxygenated artery or vein, but simply which direction is it coming towards the probe or away from the probe. If you're scanning perpendicular to the substance, you may actually see something show up as black, even though you know it should have flow in it. And that's because it's using math, which would mean that a 90-degree angle, the cosine of 90 is going to be 0. So you have to have your probe at some angle to the flow pattern in order for color Doppler to be effectively detected. So because it's putting more energy into you, I think it's also important to remember that we would want to put this on and into somebody as low as possible as part of the ALARA principle. And the ALARA principle is an overall arching safety mechanism in all medical imaging, and it stands for as low as reasonably achievable. So you're only going to be using these things to achieve a set clinical goal or gather set pieces of clinical information. Now, there's been no evidence to show that this in any way at medical practice levels can actually harm you. However, we would want to be prudent in using color Doppler because it puts so much more energy in, and because it actually degrades the quality of the image, and that alone is worth limiting its use to what you need it for. Now, when we think about echo textures, every tissue will have an echo texture. We've talked about some of these terms already, where homogeneous means that it's going to be sameness. So here we can see liver that has sameness associated with it. That would be a homogeneous liver. And then we see non-homogeneous, where we see the cystic structure where it's got mixes of fluid and solids inside of it. So that would be non-homogeneous, with either a solid substance or a cystic substance helping with that. Complex, of course, will be mixes of solid and fluid. Isoechoic means it's the same as well. It has a very consistent echogenicity. Hyperechoic, just like this tumor, is more hyperechoic, as is the diaphragm seen here, than the parenchyma of the liver. So these are mostly comparative terms. And anechoic, we've already discussed, is without echogenicity and would be represented as black. Well, that's all for part 2. Hopefully you'll enjoy the ultrasound scanning sessions as you learn the eFAST to help you make determinations of where fluid is, or where air is, and where it should or shouldn't be. I see with sound. What's your superpower? I'm Dr. Craig Murphy, and we'll see you soon.